Okay, I'll bring you up to date on where we stand with renal denervation and my disclosures. So basically, what we're looking at with the Symplicity 3 trial was intended to be revolutionize the whole status of hypertension. And we're looking at a patient population of 75 million, so it's not insignificant. However, this didn't happen. And renal denervation, it's not dead, but is arguably badly damaged. So I think it was intended to reduce overall axon activity, sympathetic activity between the kidneys and the brain. And at least in this trial, it was not very efficient. So the emerging options for sympathetic control, sympathetic overactivity that occurs in heart failure, atrial arrhythmias, special AFib, sleep apnea, COPD, and insulin resistance, that could be real. So in this situation, the byproducts may be more important than the primary. Now, when we look at the issues with Symplicity, HDN, so you see, heterogeneity in the operator experience was a major factor. So as in all trials, operator experience is critical. And the catheter design, there may be some criticism now of the catheter design. And the conduct of the trial, and the placebo effect being infinitely better, not a little bit, much better than the actual drug. And then the regression to mean, biased by the operator. The medication changes during the procedure, patient demographics, we had mixed heterogeneity in the patients, and just the several features resulted in the trial. Now, when we looked at the registry, mainly Australian and European, it was overwhelming. These patients had 3-year drop of 31 systolic, 16 diastolic in a 3-year period. So it was clearly impressive, and that initiated all of the interest in the whole approach to renal denervation, to the point that within that short time period, there were 23 other companies involved in RF ablation. And then secondly, implants became popular. CVRX, Rox Medical, Vascular Dynamics, and Simpara. So implants to control overactive sympathetic nervous system. And then more recently, we have agents being applied. Northwind, a bias obviously at that site, but ablative solutions, Mercator, Med Systems, and Vincristine are all designed for neurolysis via drug therapy. So basically, there was a tremendous amount of activity until we have, unfortunately, Deepak Bhatt, PI for the trial, said ineffective denervation, blamed for the trial's failure. And when we look at Symplicity 3, it met the safety endpoint, but not efficacy. So the question came up, it did meet safety, but it met safety because maybe it was underdosed. Secondly, operator inexperience in the device design and the ablation for the procedure wasn't any greater than 2 mm. So obviously in that situation with this unipolar electrode, there were, in a registry study done by Mary Geisler, there was 40% denervation achieved, only 40%, so it was never very effective in terms of denervating most of the ganglion that they were attempting. So we ask ourselves the question now, is denervation beginning to unwind? And I think it's critical that industry continues development of renal denervation because it works. So I think that industry continuing is critically important because this was only one trial, one device, and a select subset of patients. So I think there's no reason to abandon the trial. Now, when we look at the pivotal studies of Symplicity 3, you can see the placebo effect was actually better in some situations than the actual drug. And this was true at 3 months as well as 6 months. So clearly, and as Deepak Bhatt pointed out, it was not an insignificant difference, it was a major difference. So when we again look at the study limitations, we say, look, procedure variability was significant. I think device limitations and operator experience we mentioned. And most importantly, there was no neural mapping, and that's what we're working on now, the ability to map where the perineural structures really are on the renal artery. And then secondly, in the medication changes during the procedure, and again, only 40% of the denervations achieving with the unipolar electrode adequate results. And the patient demographics I already mentioned. But the bottom line is, the limitations, we think that non-targeted therapy requires catheter manipulation, and catheter manipulation creates damage. So we think that tissue damage occurred, and there are some long-term effects that are not really known with renal artery stenosis, and we didn't have any currently available data on treating aneurysms, fibromuscular disease, reintervention for ablated arteries, stents in the presence of renal vascular hypertension. And then unfavorable anatomy was a major issue in the trial because it was limited enrollment because of these features, small vessels, hostile aorta, acute takeoffs, and not certain of the penetration. And not certain of the penetration was critical, because when we really looked at that, you clearly have to get to the adventitia, regardless of what you're using. So in the meantime, if they're only going 2 mm and not greater than 2 mm, we're getting inefficient results because we weren't really capturing most of the perineural bundle. And you can see here in this diagrammatic, you can see the adventitia going to the intima and media and adventitia. You can see a 2 millimeter depth. But it so happens that when it was inefficient, not getting to the adventitia, we think that there was some damage to the intima and the media by RF, and really not being effective getting to where most of the neural activity is on the adventitia. And the adventitia has substance to it, so it's clearly that we have to control via monitoring of some sort, monitoring, mapping to understand where the distribution of the drugs occurring. And RF's the same way. So energy-based denervation must have some issues. You can see here on OCT, clearly thrombotic changes along the intima. And again, this is only anecdotal, but nonetheless it's occurring. So again, pointing out the distribution, most of the activity in the perineural structures is at 2 to 4 mm. 2 doesn't do it. You can see 30% of the patients here are 2 to 4. So denervation at this level is not that effective. So again, you have to get to the adventitia where most of the neural activity exists. So this is just another complication that occurs. So you can see the unipolar electrode here, and then subsequently in a follow-up study, sometime later, you can see high-grade stenosis at that electrode site. So restenosis will occur. The other issue is that to be effective, RF has to at least possibly someday be able to function within the presence of a metallic stent, but that hasn't occurred. So the ablation zone in this area here, and obviously very restricted to the stent level. So again, looking at ablation, you can see here, up here, normal renal artery here on the top, main, and this is main, and there's an accessory renal artery, and you can see on the follow-up now almost total occlusion and reoccurrence of hypertension in this particular patient with RF energy ablation, high-grade stenosis at this site. So we think that ultimately there have to be some new platforms. We have to start looking at perineural therapy with drug-induced activity via the stent. And here is an example of what we're looking at this point in time. So this is a balloon, and the balloon has a micro needle on it, 0.006, so it's a very tiny needle. And then the needle is delivered clearly to the adventitia, and you can see distribution here are the axons. And this is the area we want the drug to be receptive to the axon. And what we're dealing with is the drug is a receptor, and the receptor then takes it to the axon and basically causes apoptosis of this entire efferent afferent complex. So that's the theory behind drug. And you can see here in the animal studies we have, here's the balloon with the needle, there's the balloon's down. You can see actually the balloon here and how it effectively is up against the intima and deploys the stent. So I'll show you one quick case we did. We've done 7 cases, first in man in Tbilisi, Georgia, with good results. So basically angiogram demonstrating clear-cut normal renal arteries bilaterally. And then you can see the flow here, normal flow, initial renal angiogram, and the sheath for access to the left renal artery. And then subsequently with the balloon catheter in place, this is the segment of the left renal artery. You can see position of the balloon with the microneedle. And then subsequently on the follow-up, should work. And now here's the balloon up. And you can see the balloon, total control, no flow distal to the site where we're delivering the needle. On final result, you can see no disruption of the intima, no dissection, no thrombotic changes, no evidence of perforation or significant spasm. So basically, this approach, which is relatively new, is nothing more than an angioplasty. It's 10 minutes on the right side, 10 minutes on the left side. And the drug is, like I say, receptor attached to the axon, so it's very site-specific. Now, what is interesting is the development occurring now at the carotid sinus, carotid body, and there's a significant amount of research going on at that level, especially for heart failure. So again, modulating the perineural structures by neuromodulation could be a very, very effective way as we look forward to managing hypertension. So the comorbidity sites are atrial fibrillation, congestive heart failure, with marked improvement in ejection fraction in a small study being done. I think pulmonary hypertension and chronic pulmonary obstructive disease, and certainly AFib at that level, and other indications, insulin resistance. So it's a whole host of other areas where sympathetic overactivity exists. So I think, renal denervation's had a major setback, but I don't think it's dead. I think it's just a matter of almost like the perfect storm. So I think sitting on the sidelines for the next year till we recover, either with RF or some energy source, or like I'm pointing out, probably some neurotropic site-specific drug could be very effective. Thanks.